be, uh, yeah. Oh, I got a note that my camera, I'm blurry, so let me see what I can do about that. Maybe my background. Anybody guess where I am, by the way? Let's see if I can show you out there. So yeah, I'm in Chicago today. So we'll say, all right, got it. All righty, so let's move on and let's go ahead and start off since it's going to get recorded anyways. I was hoping that some of the players would be on the phone, but if they come on later, you can maybe re-ping it. But Jose, can you tell us a little bit? You're the president-elect and soon to be president. When do you officially take over? Is there some like meeting at the NAMSP meeting in January? When does that transition take place?
Hey, good morning, everybody. So obviously, we're looking forward to our meeting that will take place in January in Tampa, our annual meeting. And as at the end of the meeting, I transitioned, obviously, from our good friend Mike Levy, as president. I transitioned to incoming president at the end of that meeting. So definitely, so I'm looking forward to the meeting. It's going to be a very, very well-attended meeting with lots of people registering already. So if you haven't booked your trip, get it done.
Yeah. So yeah, I'm all set, just so you know, okay, which is good. So thanks. Well, think you guys had some elections or something last week, right? For incoming president-elect, and I think also a secretary treasurer that I know of. Can you tell us about who that was?
Yeah, absolutely, Paul. Obviously, as you all know, we just finished our election cycle for sort of the new incoming leadership for the association. And obviously, Kevin Mackey, one of our good friends here, is our incoming secretary treasurer for the board of directors for the MSP. And then Doc Kupas is our new president-elect. Obviously, they will be taking office at the meeting, at the end of the meeting, so where we kind of hand off all the transition and so forth for the leadership position. So, you all know them, great folks, very dedicated to the work that we all do. So, certainly looking forward to serving with them for the next upcoming years.
Yeah. Okay, good. Well, yeah, and we're looking forward to having you there too. So it sounds like the board's gotten very eagle-eyed, and I love it. So you guys have, and it's good. I mean, I think that really it creates a more of a, a good connection there. So thank you for being here. Hey, well, I got you on. Let's know what's going on in your neck of the woods, so to speak, right? Yeah, what's happening in Wake County, Raleigh? Okay.
Yeah, Paul. Obviously, as you know very well, Paul, and a lot of our friends and colleagues here, and certainly looking forward to hearing from all of you in some capacity. But we are right now, staying very, very, very busy and sort of crushed with the amount of RSV and flu that we're seeing extremely early that we ever anticipated in our community, at least in prior years. So that's having a significant impact in EMS system operations and so
Well,
forth.
let me interrupt you there. How is it having an impact on you? Are people calling 911 for like respiratory distress for their kids, or
Yeah.
is it something where you do transfers, or what's happening? Why is it affecting EMS? I understand children's hospitals, right?
Yeah, it's a little bit of combination of things. Obviously, there's more call volume when these events start happening in the community, just by the nature of the effect that it has in the community. And then number two, the consequence of the boarding and the lack of throughput or capacity downstream in the EDs affecting our ability to get in and out of the hospital fairly reasonable amount of time. So those things compounded with the other factors that we have in the community and in the EMS and so forth, it's carrying a strain, and I'm sure we're not the only ones seeing it.
Yeah, so part of what I'm basically helping with the medical advance for a tour right now, and I've been reconnecting with everybody. That's what Chris and I have been talking about, for example. And I'm in Chicago now, and it's interesting going to the adult emergency departments. They're seeing kids over there because they're overflowing from the children's hospitals can't handle it. So we're seeing them over in the adult side. I think that's going on around the country as I talk to people as I go from one place to the next, because I'm saying, so where do we take pediatric cases? And they're going, well, I don't know, because it really is busy. And we heard that from also last week from Charlotte, so it's been tough. All right.
Yeah.
Well, anything else new then from your area, or anything that anything we should know about from NAMSP outside the issue of coming to the meeting?
No, I think obviously we keep a couple of things. NSG wise, we keep doing work on the advocacy arena and a lot of number of initiatives. So that's keep on going, and we're just preparing for a very good, well-attended meeting in January. So
Yeah.
stay tuned. And then on my perspective on here and EMS, in addition, I was going to add that we're from a staffing standpoint, we're getting better, but still a lot of challenges that in from a personnel standpoint. But we're working through it. I'm sure everybody else is in the same boat. So.
Yeah. Okay. As long as the boat's not got a hole in it, right?
Right.
So, okay, great. Well, listen, thanks again. It's great. And we really miss you. We want you on the call more often. If you can get on, we really would, it would be great. Okay. So
No, I appreciate that, Paul. We'll do my best to keep coming. Obviously, with all the hats that I wear in the county and other things that I do, it's hard, but I'm glad to be here today.
And we're so glad you got to go to the meeting down in Florida this year. So you really contributed well to it. So it was a lot of fun. Great having you there. Okay, so let me do this. Let me jump over to a couple other people we haven't had on for a bit, I don't think. Well, let's go with Chris first because he has to get off. So Chris Colwell, what's happening in San Francisco? Thanks for the great report on the speaker's husband last week. And that was it was kind of interesting for a lot of different reasons, especially because they didn't know what they were going into in the first place, or neither did you guys, I think, later, but that was a really good case report. What's happening now on your end?
Hey, everybody. So thankfully, the media circus is now officially gone. As of Friday, it lasted a full week, but because we had, unfortunately, both the speaker's husband and the perpetrator here at the hospital for a more extended period of time than is generally the case. But in any way, they finally both left as of Friday, so we don't have the same media circus that we had before, and we're able to focus on the more immediate issues at hand. We're challenged with some of the same things that Jose was talking about. We certainly have seen a pretty significant bump in respiratory issues. And I, personally have seen more sick kids with RSV in the last 2 weeks than I've seen in the previous 2 years, 3 years combined. As everybody knows, COVID didn't really impact kids so much. I mean, this is really some of our PEM folks have described this as their pandemic because they kind of had a break for a while during the COVID pandemic. Now they're starting to see the unfortunate ramifications of that, and we're certainly seeing that here in San Francisco. So that's been our big challenge. We're still really struggling with the opioid stuff, and that remains high on our particularly for transports and as well as behavioral health. So those are all of our issues right now.
Have you changed your protocols or done at least some alerts about that people may not wake up with the usual amount of Narcan that we use? Have you done that, because, so that people aren't using more because it's probably mixed with the xylazine or whatever it is, du jour, right? The drug.
Right. No, whereas normally I think everybody is aware, 0.4, 2, maybe occasionally going to 4. Now we're routinely going to 10, 12, 14 milligrams. I shouldn't say routinely, but certainly a day doesn't go by when we're doing that both in the field and in the emergency department. And I haven't seen this many Narcan drips ever in my career. So there's no question. We have put that out both for pre-hospital and for the other emergency departments is how much more Narcan is required. And these ones where previously give 2 milligrams of Narcan, no response. You must be going down the wrong route. You got to think about something else. We still have to think about something else, but clearly that's not enough to rule out fentanyl as the cause.
Yeah, and and I was going to say, oh, go ahead. So we're going to pipe in there.
Sorry, Chris. Has your poison center done any sampling of the patients? Is it a fentanyl cogener or is it xylazine or what is it?
So for us here in San Francisco, it's much more fentanyl. They have not seen that bump in the xylazine or the other issues, but they are trying to keeping an eye on it, and we haven't seen that bump that other places have.
Yeah, the real reason is what happens in San Francisco happens in Portland and Seattle, as Matt knows. So
yeah, the foreshadowing. And Crawford, you're not changing anything over there. You're the first person to report it to us. You're not changing your protocol or adapting. You're just still doing it, right?
No, I think our people are so used to whatever the co-mixture of the day is that everything's the same.
Okay, got it.
Hey, it's Jim. Remember, everybody thought we were crazy in the Midwest. this started and we peaked 2016 and 17, and we're talking about high dose Narcan and the issues. All of it was, related to fentanyl and its cousins. And that is in fact what it's been taking. So thanks, Chris, for reporting that.
Yeah, so Jim, and let's be clear, we think you're crazy in the Midwest, but for different
Okay.
reasons.
Yeah.
And no, and Jose made a comment, I personally, it is my opinion that max dose Narcan needs to be rethought. And what we previously thought of as kind of max dose definitely going another direction needs to be rethought. I still like the idea of thinking about other things when you're not getting any impact of Narcan, but
Right.
not giving up on the Narcan as well. And I also agree with Jose's comment in the chat that what we're seeing with RSV and probably influenza as well, and John can comment on this more intelligently, but what we're seeing with that is simply 2 years of kind of a break in the normal immunity process, and now it's hitting us all at once, in my opinion.
Yeah, and we may go back and ask Eileen when she gets on, since she's, our immunologist, et cetera. But what I was going to say is let's jump over to John. John, I have a two-part question regarding what Chris just said. One, is there an community immunity factor, so to speak, involved there? I'm not sure if that's the issue with younger ones, but but that I want to see you respond to that. But the other question I have is, do adults carry RSV but don't know it because they get a mild cold, but the kids get real sick from it? Is that part of what contributes it, since we're less masked now than we were before?
The answer is yes, yes, and yes. The quick issue is RSV is RSV 1, 2, and 3, if I remember correctly. Basically, kids give it, and right now it's hitting all our United States right now. By the way, and number two, adults get it, but they have a much more milder course, and sometimes they're asymptomatic as well. So the real issue is going back to schools and lack of masking and lack of immunity to the RSV. So the kids never had RSV. So that's really, if we actually, I'm saying this a little bit tongue in cheek, but our pediatricians are well armored. They get a lot more colds and flu, and they're immune to hardly everything. When us adult doctors go over there, we just get sicker and crappier as well. The second thing is that there is a combined issue, as everybody knows. Flu is really basically pandemic. I'm not sure, and that's the wrong word. It's at very high levels in Southeast United States right now, extremely high. It's usually it's almost all H1N1 and H3N2, 2/3 H3N2, 1/3 H3N1, H1N1 as well. And then also the other issue is COVID on top of that. So we're going to be hit by three things right now in the respiratory season.
Yeah, so last time you told us it was BQ1.1, right? Is something else we should be thinking about maybe in January?
Yeah, in other words, I think if you, I think the, my prediction, it's going to be BQ1 and BQ1.1, with the dark horse being BF7. But I think BQ1 and BQ1.1 is going to be the strain that hits the United States and Europe. For people that don't know the alphabet soup, BQ1 and BQ1.1 is a BA5 derivative. Does that make sense? But there's about 4 mutations in that. There's actually 2 significances for us, this audience. The first one, if it's for a patient, the BQ1 and 1.1 is basically resistant to almost all the monoclonals we have right now as well. So we've basically lost the monoclonals, Evusheld as well as Bebtelovimab. I remember, I butchered that name here as well. The second one is that it's going to hit our workforce. If you have not had your 2 boosters, you're going to probably get a lot of sick calls, and our staffing issues are going to be really severe right now, both the hospital as well as the EMS. The EMS, my EMS providers, I would say only about half of them have ever had a booster as well. So I'm not sure if our providers are any different than the rest of the world. By the way, the vaccine is moderately effective. I sent that out to everybody else here.
When you say the vaccine, which vaccine?
But the bivalent vaccine, the United States vaccine,
Yeah.
as well.
Alrighty, and then do they have them, is it out with both companies, or is it just so far out with BioNTech?
No, it's out with Moderna as well as Pfizer right now. Moderna had a production problem. They had a contamination. That's what caused Moderna's shortage right now.
But they're both kind of equally effective as far as you know, right?
Oh yeah, Moderna has slightly higher concentration, but both are effective as well. So the other plug I want to say is that there is pretty good data right now, especially in the right age group, that if you have had 2 boosters, no matter what they are, but recommended one of the bivalent, it really cuts down on serious disease and even long-term COVID. The second one is that just came out yesterday in preprint, is that the Paxlovid has been touted to have decreased the long-term COVID incidence here as well, markedly.
Well, that's interesting then. Okay, good.
Yeah.
To know.
And John, what do you mean by moderately effective? What's that?
This is serology, Sandra.
Oh.
So it's usually the chicken, the chicken soup of serology. You just look at one study. It's like, I have no idea what to do with it. But the testing indicates that there is a significant moderate neutralization against BQ1 and BQ1.1 with the bivalent vaccine.
Okay. I'm going to come back, John, later to the Ebola thing, if you don't mind presenting that next. But I want to do a couple other things first. You'll be able to be on to do that. Is that all right?
Yeah.
Before I let you go, John, I have an interesting thing is that most of the time we see flu coming out, in December, January, whatever. So we say a lot of times I've always been told get your flu shot towards October, November. But and I've had some people suggest to me, and that may be my plan as well, being an older dude, is to I got my flu shot already, and then I may reboost my flu shot maybe in January or February. Do you think that's a waste of time?
No, I actually think that depending upon what the flu strain is, the match, by the way, is pretty good this year as well. So your flu immunity probably is 90 days to 120 days. So depending upon where you are, our flu is markedly increasing literally now, but in the West Coast, so it's going up exponentially. So we'll be seeing peak flu on the West Coast probably in last part of November, early part of December. We're still seeing a lot of RSV right now. And then COVID, the BQ1
right.
1.1 is going to hit us. So all 3 at the same time.
All right, and we think that the boosters will attenuate that anyways. It may not prevent it, but us from getting sick again. But they
yes,
okay. And then I think I'll come back to you later, John. I do want to quickly go back to the Narcan issue because we have a lot of comments. I'll start off, for example, with I'll start off with Ben since he initiated this thing in the chat, and then I'll pop into the our presidents, our NAFC presidents duet, because they've made some comments as well. Okay. So before we leave that though, Jose was asking, do you know if we're seeing any more of the antivirals? Oh, you're not, you're muted, John. You're muted.
we are seeing more antivirals. In fact, we're seeing more monoclonals right now as well. So the antivirals, by the way, remdesivir is still effective, but it's a pain. It's a 3-day dose.
Yeah.
Well,
okay. All right, let's go back to the chat. So Ben, you want to tell us about what you've been thinking about in Baltimore?
Sure. Hey, everybody. I just, it's just interesting to note because, the pendulum, I think, is swung. We see not only with pre-hospital providers, but also with bystanders, that the naloxone for somebody who's unconscious, and this is all comers now in Baltimore, granted, your odds are that it is heroin or opiate related, but the doses are extremely high. The last person I think I mentioned the chart I saw with 10 milligrams, the highest I saw was 20 milligrams of pre-hospital naloxone. So we initially talked about this for harm reduction, but my point, and I know that everybody has weighed in, and I appreciate that too, is that we're seeing a lot of complications. And I wonder, we've done a good job with harm reduction, but It sounds like we have some educational stuff to do, especially with respect to bystanders and with, area hospitals. Like, at what point does the risk outweigh the benefit due to the downstream consequences of pulmonary edema, metabolic encephalopathy, and other challenges with naloxone? So just something we've continued to see reliably, even in our jurisdiction, which
That's kind of the reason why I was pressing. That was one of the reasons why I was pressing that question earlier today. And then Mike, and then I'll go back to Jose. Mike Levy, you want to chime in on that response?
I think Ben's done a good job of the conversation. To me, people that EMS encounters who are unconscious and not breathing normally are in cardiac arrest until proven otherwise. So I think with the bystander stuff, getting people to go to compressions and then maybe squirting some Narcan in, but us ignoring the possibility of cardiac arrest, even if the cardiac arrest is due to naloxone, the fact that we're not responding with that, I think is a downside of the current movement, notwithstanding the upside of it. And then when EMS arrives, I just don't feel that it's really compelling that we give a bunch of Narcan. I mean, we know how to ventilate somebody. We can support ventilations. Most people arouse with some stimulation. Then EMS can titrate a dose that's reasonable as opposed to causing problems. And again, this thing about pulmonary edema and the like, I mean, there's a lot of different sort of viewpoints on it, but to me, it makes sense that when a person is laying down for a prolonged period of time, getting progressively, more unconscious, losing their airway, and continues to tug, increases negative intrathoracic pressure in the chest with all this tugging and the like. I think that is at least kind of metaphorically how people, end up in pulmonary edema when you flash them back into a high dose Narcan awareness with a big flood of epinephrine and the like. Again, that's sort of a cartoonish approach to it, but I think that is one of the risks we have with this. I don't see the big upside of it when we are already supporting their ventilations. I think there's a magical thinking that Narcan is going to change blood pressure problems, that Narcan is going to do other stuff that Narcan doesn't do. So I think that's my 9 cents on that. Thanks.
Great. Oh, there's inflation. It's up to 11 cents. You're okay. So, all right. So let's move over. Well, do you want to follow up on that at all, Jose?
No, Mo, I think the team covered it. I just one thing is I mentioned in the chat is obviously there's a role for Narcan. We're struggling with what is the right on, applicability in this sense, because we're using some of the science from, the 90s in a way, and you don't have enough Narcan available, right? Because of shortages. So how do you find that sweet spot? I think that's sort of the part of that analysis as well.
Yeah. Okay. And by the way, this still goes back to the whole issue as well. It sort of is that I always remind you that our two-legged stool of where we used to go breathing and Narcan has to be also supplemented with the E part, the BNE, the EKG as well, because we're definitely seeing a lot of issues there that complicated things even further. So not to get totally focused on the Narcan. And I like it's kind of getting back to basics once again, right? So it's good. Anybody else want to have any more comments on that? Like, do you want to talk about droperidol? Right? It's really funny. Chris, are you still on, by the way?
I am, and I just point out, somebody proved me wrong that droperidol wouldn't cure all of this.
Right. Okay, well, good. And thanks again for your help. Have you warned the city public safety directors about my imminent approach and rumored sighting in San Francisco later this week?
I have.
Okay, good.
We're all set. We are ready for you.
Okay, good. Well, thanks a lot then. And I know you have to get off here pretty soon, but it's been great hooking up with you. All right, so let's now move over to see what was the other thing I wanted to pivot into. Oh, Stein, do you want to tell us a little bit? We sent out a TXA thing just to get a little bit of a feel of who's using it. Do we have any preliminary results yet?
Yeah, if I can share my screen for a minute, I have a few slides with numbers.
I guess I do that. I guess I go.
Well, I think I worked out my glitches. Can you see my screen?
Yes.
All right. So let me get back to the beginning here. Sorry, I kind of opened up in the.
But this is very preliminary, by the way, everybody. Just first things. I haven't even seen this yet myself. So and a lot of times I go through things and I'll find some issues that we got to kind of tune up, like people who we don't even know who they were that were answering, right? So it was kind of funny, right? That one time.
Right, and that's a good point, because this is very preliminary, and And there's a lot of partially answered questions, et cetera. So you have to take this with a grain of salt, but at least it gives us a first indication. Our inclusions in this, it's important, are for ground EMS only and parenteral use of TXA. It's no topical use.
Okay.
And the respondents, there were 36 respondents total. Out of those, 24 used parenteral TXA in some form, and obviously 12 do not.
Okay.
The use was for presumptive post-traumatic hemorrhage. Let me get this, you're in my way of, the faces are in the way of my numbers. For post-traumatic internal hemorrhage, 20 of them said yes. Brain injury, only 6 said yes, and non-traumatic bleeding. We listed ectopic and GI. I can see from the responses that people got confused. We probably should have put ectopic, GI, etc., so that it included like postpartum hemorrhage, etc. And so that number is a little bit off because
Yeah, I thought we did have that, Tetra, so too bad. Okay, go ahead.
yeah. And so when we get to other reasons that people put, some people put postpartum hemorrhage, why isn't that in there? So we captured them there. And then others had some caveats about how they use it, different definitions, severe traumatic shock with a vital sign parameters. And so you can see some of those responses there. We asked if they were using TXA as part of a blood product transfusion protocol. Only 2 answered yes. And then independent of the blood product transfusion, 11 answered. And then in specific circumstances only, we got 4. And those were like for tactical responses, lengthy transports to a trauma center, et cetera. The lengthy transports and urban area was the largest answer there for in specific reasons for using it, that they only use it in lengthy transports. So we asked also about the route of TXA administration, IV, IO, IM. Most of them are using IV. There were, as you can see by the numbers, there were a lot of people that answered yes, we're using it, but then they skipped the route of administration and the dosing. And so we have to go back and we have to ask people to fill that in a little bit more. There are a couple of respondents that said IM, but mainly IV and IO. Some of them overlapped where they allow IV and IO, etc. For the dosing, this was interesting because it seemed to be even across the board for those who responded, that 2 grams up front versus 1 gram only up front versus 1 gram pre-hospital, and then another gram over 8 hours that's coordinated with the hospital. I would have expected that there were more that were just the 2 grams up front on scene. And then finally, there was the reasons for not using TXA for those who answered that they weren't. The majority, the most popular answer here, not a surprise, but this is the trauma surgeons don't like it. Regulatory agencies don't allow it, or there's not enough supporting data in their opinion. Short transport times was an answer also. And then there was one respondent that said that they were waiting for the results of the patch study that's going to be talked about at National Association of EMS Physicians in January. So that's all we have right now. And we really do need to kind of fine tune this and allow people to, whoops, let me get out of this. Am I still sharing my screen?
Yeah, you are.
Let me get out of that.
Well, nice job. So what I'm going to do is continue to see if I can get the people who didn't respond yet, because there might be a bias if you're not using it that you don't report it, you know, that kind of here, or they may be out on vacation, like a couple of people I know were. And so, but I'd like to make sure we get all the data from across the board. It's a lot more people than I thought we'd be using. Number one, there's a specific reason which I'm going to present to you later. Okay. And it's interesting because they talked about the patch study, and that's part of the issue as well. You'll see in a second. Or not in a second, later when I talk about this, but let me say I specifically wanted to look at the 2 grams up front, which is recommended by the TCCC, versus the 1+1 over a period of time. One of the reasons why I bring that up, and I think that they use it that way, is that that's how it was traditionally done for OB cases and cardiac cases years ago. And then when they did the crash trial, they just adopted that same thing. And there may be issues with that, which I'll raise, but I just wanted to see what people were doing now. And we'll come up and I think I'll personally give you a presentation on why I think and Stein's heard it, it's interesting stuff, right? So it'll be kind of a fun thing to do, but I wanted to get the data first before I biased anybody. So, all right. So it'll be kind of cool. So let's see. And by the way, I talked to the PI of the patch study and I gave him that information. He said that was very helpful. So it'll be interesting. They'll look at the data accordingly. All right. So then let's see. Anybody have any questions for him on that? David Miramontes, you've only been using it for what, a couple of months now? I'm being sarcastic, of course, right? Tell us what you did and why you chose to do it. Are you still there, David? Hopefully he's still there. I see his name on the list. I'll call out again. David Miramontes. David Miramontes. All right, well, maybe we'll get him on later on. But anyways, to answer the question for him, they've actually been using it as part of their blood protocol, and they do give what I understand. David, here you go, right? You're coming on?
Sorry, I was driving.
Oh, yeah, sure.
Yes, we've been using it with the blood protocol. We're using it for postpartum, after delivery. We're debating whether to use it for ectopic or during the laboring process. Usually our OBGYNs want to wait till the placenta's been delivered. I'm not sure why. I'm trying to figure that out. But I mean, TXA, there's no downside that I see, except for in the head injured patient that we're waiting to get more information on. But, people take this orally all the time, like for heavy menstrual bleeding. They use it in third world countries. It's really a pretty safe, effective drug for the most part. So the question, and we do the 2 grams up front, just like you said.
Yeah.
And that was cleared.
Yeah.
That was cleared with our trauma centers. So
right. Oh, you guys are very progressive there too. But what I was going to say is that I'll come back and talk about that. And I think I've got a resolution. And Mike Levy and I have talked about this in the past as John Jew, and you'll see. But I want to reserve that until after the all this is in. And we're actually re-updating the blood survey to people. We're still waiting for the people who did not answer. Again, I want to make sure I'm ruling out some kind of selection bias there. But I think we got some better. It's like a lot more impressive than I thought it was going to be in terms of use. So it's kind of cool. Did that go out again by any chance, Stein? Did you reboot that?
Yeah, everybody who had not responded that you ran by me has gotten an invitation to respond again.
Okay, good. All righty. So, and I was going to go to Dave Persnick, but I think he had to get off to do something or other. Well, we'll leave it at that. So, but let's go ahead and go to Sandy Schneider, because you had some announcements to make, right, Sandy? Are you there still? I hope.
I am indeed. I wanted to share with you, I'm just putting it in the chat right now. Oops, why didn't that work? Putting it in the chat right now. ACEP has been hearing everything you guys have been saying on this call and all the other calls regarding boarding, crowding, et cetera, and the effect it's having, not just on our healthcare personnel, but on the patients. Many of you may have seen that we've been collecting stories about how bad this is. And I got to tell you, for someone who's been as involved as I have been over the years in really bad situations, these kind of really got to me. Anyhow, we sent a letter to the president, and we sent it with copies to a lot of other officials. The letter asks for a couple of things. It primarily asks for a summit to be held. And the issue here is not to just look at the hospital, what can the hospital do, which is where we've been putting a lot of effort over the years and has quite frankly gotten us nowhere. But this is really going to be now, what can the feds do? What can the state do? What kind of care? What can the Joint Commission do? What are the carrots? What are the sticks? what are the bigger pictures that can move the needle on this and hopefully get some relief. I urge you to read the letter. It's long. I apologize for that, but as you read, you'll see why it's long because it really is compelling. It went to the president yesterday. Today we got notification that Asper would like to meet with us, and we're meeting with them tomorrow. So apparently it's already had some effect. I would mention also that Chris Kang, who's our president this year, did meet with the Surgeon General last week and made the same request of him. But then we felt that we had to follow it up with this letter. So just letting you know where we're at.
Okay, thank you. That is interesting. I hope it goes well. We'll see how it is. And you guys, you'll see what happens with the elections as well. So I don't know if that'll have any effect one way or the other, that kind of thing.
Yeah.
So.
The other thing on this, guys, is if you have a big picture idea about what can be done, not so much, please send them to me because we're really looking for things that can be done. And again, we're not looking at this at a hospital or EMS or emergency department level. We're talking about something that's quite bigger.
Yeah. Okay. Well, thanks for saying that up to us. So is there anything else to report from your seat, so to speak, right?
Well, this has been a sort of all I'm living for the last 4 to 5 days. So nothing, just thank you guys for everything. I know that it's really rough out there. I know it really, really, really is rough out there.
Well, thanks for your support too. Just great to know that we got someone always looking after us as well. And then speaking of looking after us, Julie's looking after me, and I'll see you a week from Friday, I think. Okay.
Yeah.
So,
yeah.
All right. Good. All righty. So let's then, if we have nothing else, let's move on to other folks. And let's start off with, let's see, I got to get this chat thing moved out of the way so I can see who's on my list here. So first of all, let's see, there was someone I did want to talk to. I'm just saying, oh, hey, Joe, Holly, can you pipe in again? I think you were going to try to make a comment before the chat and I never got over to you. Anything that you want to add there?
No worries. It was just related to the Narcan discussion we were having earlier, and that we have sort of put in place, excuse me, a bit of a soft stop at some point. Stop giving Narcan and just manage the airway. Obviously, that's challenging for bystanders. But if our guys are noting that bystanders have given a lot of Narcan, they just move straight to airway management definitive.
All right. Okay. So it sounds like there's a kind of a working trend there, so to speak, right? Hey, and by the way, on the CME level, today's CME numbers, if I remember correctly, let me pull them up, are 15326 for this meeting, 15326. And for the Florida folks, it was 15328, 15328. Okay. I'll tell you, this is like, for me, I think I'm over 100 hours now of CME. It's like amazing, how much we get out of this thing from that point of view. Okay, so let's see. There was Jim. Let's go ahead and see if there's any reports from you then, from either IAFC, IAFF, or whatever. Okay.
Yes, thank you. And my video's not working for some reason. Again, the big meetings.
I heard that People Magazine had Sexiest Man of the Year award, and I understand that went to you. So that you just that's why we're trying to get. Yeah, right. Okay, got it.
Yeah. Okay. I sent him a picture of Chris Colwell, and I won. So
okay.
All right. The big meetings for both organizations have taken place for the year, and our future is a lot of technology. So the IACP, the Chiefs of Police, had a huge meeting in Dallas, and about a third of the exhibit area was technology. Some of it around drones, and some of it around the use of artificial intelligence, which is becoming much more progressive in law enforcement. The fire chiefs had in Dallas a meeting on technology. So it's the Technology Summit International. And for all of you and for your people who oversee technology for your department, this is a must go to next year. Microsoft was the big exhibitor and sponsor of the meeting with some of their subcontractors. Australia is a huge use of Microsoft products to facilitate fire and emergency services, and they showed off a lot of that technology. And really progressive use in everything from scheduling to report writing to analytics, mapping, both internal and external, for search and rescue, for wildland fires, and for structure firefighting and rescue. So that's the big issues. There's huge concern in both public safety branches about our ability to recruit and retain. So nothing different than what's going on in the CME world, or then in the healthcare world. And both of them have aggressive schedules. We get together next year. So that's it, Paul and everyone. Glad to answer any questions.
Okay. No, thank you. Anybody have any questions for him? Okay. Okay. If not, hey, Bobby, would you add anything to that, by the way? Bobby Halton?
Yeah, I'd be happy to, Doc. And I don't have any letters after my name, so I apologize. I'm letterless attendee. And now I know exactly how Slingblade felt when he read the Bible. Most of the conversation went right over my head. I'm just your resident run-of-the-mill firefighter here from FDIC. And thank you, Dr. Pepe, for agreeing to bring some of the Eagles to FDIC this year. It'll be directly after the GEMS games. And so what we're seeing on the fire side is right now we're struggling, obviously, with the lithium-ion battery issue. And we're really not sure from the emergency medicine standpoint as to what the toxicity issues are going to be on that. We know it's mostly hydrogen gas. There's some fluoride gas as well. So that's a real concern for us. The thermal activity obviously is devastating. And as you all may have seen, the people jumping out of that window in New York City last week, that was a scooter battery that exploded in that apartment, and 38 people needed to be rescued. So we're not sure what we're dealing with in terms of the respiratory and other issues like that from massive amounts of hydrogen gas that we know are being emitted, and the incredible thermal that we're seeing. So that's a big concern. We're still looking into the PFAS, PFOA in the gear. We're not really sure, what the level of toxicity of that is either from a medical standpoint. I know Dr. Burgess and others are looking into that for us, and Dr. Augustine are looking into that for us from the IAFF and IAFC standpoints, and then just from the general population. But other than that, the Narcan usage was a fascinating conversation, because I know our medics are, struggling with that out there. Full confession and disclosure, as a paramedic, I once gave Narcan sublingually just to see what it would do. And I got a very fast, violent opioid response from a person who cleaned my clock with a right hand haymaker that took me to the ground. So I'll never do that again.
I thought you were going to say he gave you a tongue lashing. So, but whatever. So,
oh no, this person woke up so fast, and they knocked me down, like they dropped me like third period French. It was not good. So I don't recommend that as a therapeutic alternative. But it was interesting to see how fast it worked. I mean, sublingual, it was amazing. Yeah.
All right. Well, let me move over then. Since we're talking about FDIC, let's go back over to Josh Hartman from EMS World. And Josh, anything to report on the meeting going back that you guys held last month, and anything new to report on, or you get back feedback from the meeting? Or sorry, Josh, are you there? Maybe not. Okay, got it. He may be off doing something else. We'll see. So anyways, Josh Hartman, if you can hear me, I was going to try to get you on. Okay. If not, let's jump over to Mike Levy then. Mike, I understand that the thing that, you're as president of NASP, I'm asking you, but Sandy Schneider said that you guys signed off on that as well. So you were involved with that report to the president, correct?
That's correct.
Okay.
Yes, and we're grateful. We're very grateful.
Yeah.
Thank you. Thanks.
And is there any comments that you want to make about that, by the way, from your point of view?
Well, it's an important letter. It addresses the hospital side of it. It was definitely, addressing that major concern, that major challenge. There was mention made of the challenges faced by EMS. We need to continue to sort of prosecute that case too, just from those that live this life, in terms of what it does to our people, what it does to morale, what it does for our patients, all the things that are the downstream consequences. And I think also some of the solutions we might be able to help with proper funding and infrastructure that EMS with our MIH programs and our talented clinicians, where we can move this thing, basically moving it a little away from the hospital to help with some of that offloading, and also the hospital and the home and all the ways that we can help in that venue. So I think there's opportunities there in terms of solutions. Right now, all we're facing are the problems, it seems like, unfortunately.
Yep. All right. Well, thank you so much. Hey, before I forget, I just wanted to give you a quick highlight, sort of break tease, so to speak, of next week. I was just here at the Heart Association meetings in Chicago and got to see Sheldon Chesky's present his paper on double sequential, et cetera. And it's really pretty good and may end up being changing our practice, et cetera, if it's not already changed based on the information we've already had. So he's going to come on and present it. Not only to our Seagulls group on next Tuesday, but also to us, like around, I guess, noontime Eastern, et cetera, for those of you who are looking forward to that. And then Amal Matu and Corey Slovis will be commenting, critiquing, and giving their opinions about where we go next, et cetera, as well. And hopefully you guys as well. Just wanted to make sure I threw that in for those of you who've been looking at this for a while. And John Jew, you've been a proponent of it in a lot of respects, especially for non-cardiac cases, right? If I remember correctly. John, you want to make a comment? And then I'll have you do your Ebola thing.
Yeah, we've been using that since I think 2014, 2015. We've been with some success as well. We've also our region has instituted ESMA law, albeit with some not great data as a second line antiarrhythmic here as well. And we're also looking at earlier use of amiodarone in VFib as well, but on a research basis. But
Yep,
yes,
okay.
we've been using double sequential for at least 6 years.
And then the issue is that are you using APs and the usual placement and then an AP, or how do you?
No, our strong preference is to use anterior posterior, which obviously we're a Lucas community, and so that actually requires our firefighters that don't have the Lucas to put the AP pads on first before the Lucas goes on as well. So,
Right. That's what I wanted to raise.
Yeah.
We're doing the same thing in some of our jurisdictions as well. So which has been cool. And then,
by the way, Paul, sorry to interrupt, but the Jesse's data did show, as you well know, that there was a difference between the vector change. Does that make sense as well? And so.
oh, yes. Yeah. And I think that's why part of what I was bringing up is people are thinking about it. They need to know that that they probably may want to go put the pads on different. I don't think actually putting on the pads there is actually maybe even a good place to go in the first place anyways, right? So, obviously for the bystanders, that may not be as big an issue, but for us, maybe it's something that's achievable. What's your opinion on that?
Yeah, the Lucas poses a major problem where the pads go on, and there's hours of discussion. You put it on top, you put it on bottom, you put it on the side,
Yeah.
etc. So right now we're putting it in the belly if the belly allows, but it depends upon the habitus of the patient.
Yeah, and then do you go? Is it underneath the scapula when you're doing it, or
Yes, it's in the inferior border of the scapula, obviously left scapula.
Yeah, not near the spine and so over, yeah, kind of, which is a point I'm trying to make. So, okay, so actually, one of the earlier adopters was Jose and his team over there in Wake County. And Jose, what's your data show? John, I'm going to have you come back and comment about some of the stuff you found. But let's just get a more generic thing from Jose. What can you tell us about that?
Yeah, we can definitely bring in more updated data, but we pretty much have evolved over the years to better, outcomes and survival from cases. Obviously, we didn't structure it in the same way that the publication and study that Sheldon just published. But yeah, we've been, doing it for a long time, as you all know, and we've had success with it. Obviously, the number of refractory cases in the system are small, but actually we believe in the concept, and that's how we, publish the initial series to describe it, but we have evolved it and refined it since then. And as John knows, he's been polishing and showing some of the data that he has in his system, but we've shown termination and survival on cases as well.
Tell me, so what's your protocol? How soon do you do it? Okay, let's say you've tried a couple of shocks or 3 shocks or 4 shocks, or you go into it pretty quickly.
We try now to go quicker, and we tried the vector change earlier than we have typically did when we published that case series several years back. Sorry, I'm in the street, so if you hear any background. So we tried to obviously do the several first shocks, single shock, but we changed to a vector fairly early in the recitation process, and then we do double sequential. And we've been doing it that way for some time.
So let me just say, let me just sort of see. So do you put one pad as you start off, one pad sort of underneath the the right scapula, and then one sort of a hand breadth down under the armpit, right? And then where does the next one go on? Where do the pads go on after that? Where are they placed? Oh, you're muted, by the way. You're muted.
Can you hear me? Okay, here we go.
Now I can hear you.
So we placed the second set of pads. If the first pad was placed anterior posterior, the second crew that comes in pulls the other one anterior. So we can do it that way. So we try to the second end, because the second end crew that comes into the recitation then applies the second pad in the different form, and then we just change the vector.
But a physical, just as a physical, image of where you put it on, are you putting the other one sort of like right over the heart or left side of the sternal border, and the other one under the scapula, as John described?
Yes.
Okay, got it. I just want to make sure people have an idea of what that is and how to do it for those who have not been doing it so far. So good. Well, thank you a lot. Let's go on, and then John, before I have you go back, you had some interesting findings, I thought, early on, John, that you found a lot of your saves were actually not in the people who had ventricular fibrillation from cardiac disease, but oftentimes from other causes, is right? Like the non.
Yeah, that's currently correct. Our data on the survivors are the ones that don't have VFib, coronary artery VFib. In fact, most of them did not. The second data that we actually had is most of the ones that, at least on the prior, before we converted the to Chessie's methodology, was we shocked after 5, was that most of them converted if they were going to convert after the second shock as well. Right. I think Jose's data matches that as well. The the question that actually comes up is, I just ran our data. We have about 400 cardiac arrests starting with the new protocol. Again, matching Chessie's starting after the 3rd shock as well. So we're talking about basically refractory VFib versus recurrent VFib. That's number 1. So we've had 400 cardiac arrests a year, and about 25% of them are VFib, and we've had about 20 25 basically individuals going on to Chessie's. So 25 out of probably 100 in double sequential.
Hey, Mike Levy, can you just put an editorial comment in there about we don't have refractory VFib? It probably, we should get rid of that terminology. I mean, for you, you look at.
I think it's an important point. If you look at your code stat.
I just, when I went back to my my earlier days, I went back and looked at the termination resuscitation. I never used the term refractory. I said persistent or persistently recurring, ventricular fibrillation was, I think, the terminology. And so Mike will probably agree with that, right, Mike?
I do. I mean, there's a large study out of the Netherlands looking at all of the AED data, but, just anecdotally and personally, it's just amazing to me how many times we have recurrent, and our current protocols where we go immediately back into CPR, we often miss those. And when you look at your code stat, you'll see, how many times you actually have some conversion.
Yeah.
So I think mostly this isn't an electricity problem. It's a VF problem. We're pretty good at shocking people out of VF. It's keeping them out of VF that's the problem.
Right.
So similarly to what John was talking about, we're moving to amio, right after the second shock, as opposed to giving any epinephrine. We're looking at ways to stabilize the rhythm. I'm a little concerned, even my own system, of changing vectors. When I look at it, I've actually had the vector be successful And so where we're going now is really terra incognita. You're going from a vector that actually works and you're changing to a vector you don't know does work because you've not seen the conversion, just because of limitations in real time.
Yeah.
Anyway, those are kind of concerns, but I'm fascinated by Sheldon's thing, and kudos to Sheldon for getting a big study like that through. I think it's very provocative, but I got to say, I'd take it with a big grain of salt in terms of looking at your own data.
Yeah. Okay, well, good. Thank you very much. I just want to make sure everybody understands that at Turo Comma, it was a good job. So I hope that didn't sound too patronizing, by the way. No, but it really is great work and great. I just love the fact that you're thinking differently, and it's really cool. So thank you so much, Mike, as usual. You've been a fantastic leader here for us. So, hey, speaking of which, I just saw Kevin McVaney just got on, and Kevin's actually interesting because he just recently actually turned down a job to be a big deal at the Denver Health and Hospital System, and is actually doing something interesting. Is sort of taking kind of a sabbatical, but that means you're going to also have to become an Eagles emeritus, right? Kevin, how are things going on? How are you? You want to comment on that?
Well, so my first comment is like, I got to follow a term like terra incognita. Like that's totally like a $25 word there that I can't keep up with.
We'll send you Latin. We'll send you a Latin book. Okay. Translations, right?
But yeah, actually just, I've been spending some time talking with my wife and thinking about the things going on, and I'm 54 years old and I'm not done working, but I need to take some type of a pause so that I can work another 10 or 15 years after this. So I'm stepping down from Denver Health. They offered me a few other things.
Stepping for you, not stepping down, but stepping aside.
Stepping aside. Actually, that's a much better
exactly.
Much better
stepping up, as I thought in my case.
I'm running out of bounds to stop the clock and take a pause.
Yeah.
So I'm going to do it for a year is what I'm shooting for. We'll see.
Yeah.
We'll see what happens. But things are very, very good with me and my wife and family. So, but I was going to say, number one, this group is so amazing. And Paul, I'm so grateful for all the things that you've put together through this and the work that we've done. I don't know that I'm leaving Eagles because I don't think I'm done with medicine. I'm just going to take a break. But if you know people, I still think I actually hold, like, if not the best, one of the short list of best EMS jobs in the country, because it's an academic job and a great residency with medical direction over the entire 911 system and great research support and all that kind of thing. So if you know people who are interested in a job like mine, we will be doing a national search.
Cool.
So
maybe I'll apply. So right,
maybe so.
Is it near
shock
the
factor
or something? Yeah, the shock factor. Yeah. Well, maybe because you could say it's an affirmative action thing that they have to hire elderly, aesthetically challenged people. That's what it is. But it's just
wear the right black T-shirt. I think your chances are going to go up.
Here we go. Look at, I'm wearing my PO6, so I'm all set. Hey, so and this is actually cool because Colleen is not working, and you guys are empty nesters now, if I remember. Is that right?
We are. We're going to. Well, one thing I'm looking forward to is sleeping at night. I'm going to see what that's actually like. But we are. We're very much looking forward to a little bit of time.
I think everybody on this call would say, please feel welcome to stay on with us, like Terry Valenzuela there. And it's just great to have you on board. Okay, so which is good. All right. So and before I go over to, so thanks very much, Kevin.
Thank you.
I'm glad you got on. Hey, Rob Dunn, I do want to just see if there's anything we need to know about before I go to John, do the thing on Ebola.
Yeah, well, we're in the pediatric apocalypse as well, just like everybody else. All our hospitals have spun up incident command. We've got, haven't had an available bed in weeks, so everybody's backed up in the emergency departments. One thing I did want to mention, though, just to kind of get
one thing I want to get a sense of, and I should have asked other people this. Are your cases all the ones that are the kids that are in the 2-month, the to, 2 years group, or is it go higher than that? Is it up into the 4, 5, 6-year-olds, or what are you seeing?
Under 3 for us.
Yeah, okay, that's what I figured. I just wanted to see if I'm just biased by my experience in the past, that's all.
I just want to ask a question. People can respond. I know we lost some people by this point in the call, but can respond in the chat and maybe reach out. I think all the states use some kind of state information system for beds and for situational awareness. We use EM Resource, which I know a lot of states use. We have had significant problems with that, with all of our health systems putting in wildly inaccurate data in there, not following the directions, it's very easy, right? The directions are in there. They tell you it's about real staffed beds. A lot of ours just put their licensed bed information in 10 years ago and we started using it and have never updated it. So a lot of places look like they have a lot of beds when they do not have these beds. And in our state, the big problem is that goes to a series of elected officials every single day through a bunch of gateways. It's not like the officials really look at it, but some staffer looks at it and says, oh yeah, it's not so bad. Those hospitals are just whining again. And I don't know how many people run into that problem in their state. It's something that I would love to see people do a better job on, frankly, because it drives me crazy, because then I get a call saying,
well,
what are you
here's the
talking
deal.
about?
One of the reasons why Libby got off, because she's on with the CDC right now. She was on our call earlier. She had to get off to go work with the CDC, and I'm going to put her to that task. She's a state health director. So, and we'll maybe get hold of Dr. Shepke as well and ask him that question. If you could be on next week, we'll just ask him and put him on the spot. How's that? Okay. So.
Yeah.
Okay, good. I don't, anybody else have any insight to that, or Sandy, are you still on? I don't know if Sandy's still on. I don't think she is. I don't know if there's any other comment on that. All right. Anything else then before I go over to John?
No, we can talk about some of the what's going on with that NREMT changes here, because I don't think anything's happening until after the election.
All right, got it. And hope Ryan's enjoying this with you today. So, and by the way, I ran into a bunch of people from over in I think Wayne State just the other day, and it was kind of good. It was with Brian O'Neill. They were presenting a paper here I started throwing Dutch girl donut stories at him. I said,
Nice.
It was pretty.
Yeah,
good.
that was Shobi Matthew, who was presenting the poster of mine and our EMS data that's there about the hospital imbalances that we see in terms of outcome. Is a guy that we've mentored since he was an undergrad, and he's almost done with med school now. So sorry you had to hang out with Brian, but that's I couldn't make it to rest this year.
They were kind of surprised that I was throwing out all these like local things. Are you from Detroit? And I go, no, and they said, who are you? And I said, so I just threw my t-shirt out like that. Doesn't matter. I'm in Signet. So then I said, but if you want, that's part of your job. You have to investigate and figure out who it was, that kind of thing. It'll be fun. So I just wanted to give you a heads up in case it comes up. All right, because I dropped your name. Hey, so let's go over to John Jew. Thanks a lot, Robert, as usual. Okay, John, do you want to give us an update report that you want us to know about? Because it looks like Ebola is raising its head again, right?
Well, I think Ebola really is, quote unquote, as stable as you can. From the disease point of view, they're having a lot of trouble. But as of November 2nd, Europe CDC said there were 131 cases. I'm sorry, 131 deaths. Of those, 18 of them are healthcare workers here as well.
Wow.
But I think the real issue there right now is, number one, is Ebola, what's the threat to the United States and Europe? The answer is very low. Number two, what was the reason for the alert that CDC put out? The answer is that is probably, in my guess, the approval of the BioFire Ebola Sudan assay that actually was approved by FDA 2 or 3 days ago. So it is the importance of that. It is the first commercially available lab assay that could be used in the United States to diagnose Ebola. And that's why the laboratorians were included in that messaging here as well. So every state in the United States has its laboratory that's been designated. It's called the Laboratory Resource Network Biological, NRNB. B is the acronym. So the bottom line is that we do have the BioFire assay. By the way, most hospitals have a BioFire as well, and so it's a commonly available commercial agent here as well. But like everybody else, we're dusting off our Ebola response in fire and EMS, especially our hazmat unit.
Okay. And then as usual, I say, make sure we're regularly asking, you said travel history and particularly out and double it up with out of the country, you know, that kind of thing. Even if you're from another part of the country, like let's say if you're from Portland, I always make sure we track those people for who knows what kind of illnesses they're.
By the way, we have about 20, 25 people just in the Portland metro area that are from that area. So it's don't make believe if you're in middle Utah that you're never going to see this here as well. So
Exactly right. That's kind of one of the reasons I was bringing that up.
Yeah.
So so let's now go over to Ben Weston. You know, you're the sort of public health official there in your county, and or at least senior advisor. And any response to Rob Dunn's comment about the data collection or any reflections on that?
Sorry, Paul, I was multitasking here, so I didn't.
I know you are. That's why I give a little bit of a heads up. But go ahead.
I can give updates here. I didn't hear Rob's comment.
Oh, sorry. The question was, did you hear Rob Dunn's comment about that our data may not be the strongest or as complete or robust, and it's all over the map sometimes, especially with respect to these kids with the RSV, et cetera.
What I was talking about was the state reporting systems of open beds. We use EM Resource. I know some states use other products, but you know, all the states have something that gives situational awareness to folks. And it's been so consistently inaccurate. It just literally, it's like a daily drives me crazy. And then I have to forget about it for a while.
Yeah, we use EM Resource as well. It's been pretty good, actually. We've worked with them over the last few years, the hospitals, especially in the southeast region of Wisconsin, which is where I am, to get them to input accurate data. So ours has been pretty good. When we have a situation, we certainly ask them to quickly update their bed counts to make sure we have the most accurate numbers, but it's been pretty good so far, or recently, I should say.
All right. Well, I don't know what to say, but we'll still pursue that elusive question next then for you. But thanks for clarifying that for me, by the way, as well. So, but and then which is another good question is: are we only tracking? Just going back to the RSV itself, are we actually tracking the data pretty well, or are there people don't come to the hospital and so we don't know? Which is you know, a good question as well. Just like anything else we had, just like COVID probably for a little while. I bet you after the original bout, I bet you there's more people that had it that we didn't know about and so on. But any response to that though, Ben?
Yeah, I mean, RSV, I think in particular, you know, for COVID in the past, people had sought out testing, and now it's mostly home testing, so we lost that data. But I think RSV even more so. People aren't typically going just to get tested. It's usually if you go to the hospital, to the ED or to your clinic, they may test you. But I think we're, you know, dramatically undercounting, which is why sometimes just the surveillance system for influenza-like illness and things like that in the pediatric population tends to be a little more accurate.
Yeah.
The trends tend to be more accurate, I should say.
Okay. All right. Any other comments there? Thank you very much. I'm trying to think. And then let me jump over to, hey, Rob Glatter, just wanted, if you're on still, aren't you? From Medscape? Are you there, Rob? Maybe not, or you're muted anyways. Looks like your video's on. All right. So it's Rob Glatter, if you happen to hear me, if you're not also multitasking. Okay. And then
we've been seeing a lot of flu and RSV, and it's certainly concerning. A lot of boardings happening. You know, I think, you know, the recognition that the media has put out has been helpful about retractions. There have been videos on mainstream media that help to sort of educate the public about this, because people don't understand, you know, the mechanics of breathing, and that often it's too late. You know, when EMS arrives, when the child is, you know, severe retractions and nasal flaring, and they have to be intubated. So getting there before that occurs, I think, is really, you know, the messaging so critical.
Right. Hey, so one of the reasons why I put John is because I was glad you were on with us today and got to see the issue about the so-called double sequential, double dip, double defibrillation, and some of the nuances of it that are important that go well beyond, the data that we have out there. And there's a lot of subtleties, and these guys have been studying it for a long time. And just in case you guys are in a position or you end up reporting it, I wanted to make sure you're aware of all the, those nuances or those caveats that you heard today. They did a good job. I thought they did a good job today from the different parts of the country. So, all right. Anything to report for you, by the way? So,
nothing else. That's pretty much. Yeah.
Okay, good. Hey, John, what are you saying, by the way, for immune compromised patients, oral ribavirin has been shown to be effective in moderately to severe immunocompromised patient. Okay, got it. For what? For
RSV.
Yeah, for RSV. Okay, got it.
Yeah, I
Okay.
thought there's a commonly held, like a lot of even physicians say, RSV is a virus, you can't treat it. So if you have a very, I would say a life-threatening disease, you could treat it with ribavirin.
Okay, cool. And by the way, John, thanks for sending me that article from Thailand, because it certainly fits my bias. So it's great. And it goes along with the Marty Schreiber study too, as well. So thank you. All right. Well, listen, let's see. I guess we have a few minutes left, so let's take advantage. Terry, anything to report out of Valenzuela land?
No, Paul.
Okay, good. Thank you for being your usual concise self. That's great. I love it. All right, good. But just thanks for always being here with us. It's great to have you there. So any comments to make before I let you go? Other than no, Paul?
It's really an honor and a pleasure to listen to these discussions, and I feel like it's keeping me and my family safe.
All right, good. We love having you here. You know that. So, okay, so let's then, who else? Anything, Roger, do you have anything out of your county?
So, yeah, we're seeing the same thing with kids and viral illness, specifically RSV. I understand there have been transfers from the Maryland Institute for Emergency Medical Services Center. They have what's called C4. It's a transfer program that tries to facilitate critical transfers. They've reported on their pediatric side considerable number of transfers of children out of state. It may be upwards of between 25 and 30%, if I remember the number. And some of them are going out to CHOP, Philadelphia area, out to Virginia and other places like that. The other thing that we're evaluating that's new is we were able to get funding, as I mentioned in a previous meeting, we were able to get funding for a transport destination officer, which was a resurrection of what we had during the declaration of emergency during COVID, where we got some emergency support to put a sort of a load distribution officer in our system. So we were able to get that back in the budget after a reprieve, and we're evaluating. We're going to reevaluate its effect on cycle times for ambulance, get our ambulances back in service. So that's the big news in Montgomery County right now is seeing if the transport destination officer matches the good results we had from a study that we published in PEC, I think online a couple of months back.
Right. Okay, cool. Well, thank you very much. Hey, Josh, are you there? Josh Hartman, because I was calling on you before a couple of times. Are you still on or not with us? Josh Hartman. Oh, he's well, I guess I'll have to give him a physical call and see what's going on. All right. And then let's move Dave over in the Vancouver area in Canada, over in BC. What do we have? Anything to report to us that we need to know about, or kind of some nuance from Canada?
I mean, been a very interesting conversation to follow along. Certainly in terms of the pediatric population, exactly as been said. Specifically for us, it's resulting in a large volume of interfacility transport. So that's been something for BCEHS to work to accommodate.
That's right. So you guys not only provide the emergency response, but you're also doing inter hospitals as well, right? Your system.
Correct.
Yeah. Okay.
And then on the naloxone conversation was also very interesting. Obviously, in Vancouver, the opioid crisis is a huge issue. Technically, on our protocols,
Hey, I just want to know, you made a comment, you said, obviously it's an issue, there. Why is that?
well, it's similar to what's been said about Portland, Seattle. I mean, the West Coast generally.
Yeah.
Opioid crisis has affected us as it has in many places. So I know we're all in the same boat. But in terms of Narcan dosing, we actually have in the protocol, not that it's used this much, because I do agree with the conversation in terms of, the basics and fundamentals of, ventilations and cardiac arrest care, et cetera. But it does have 10 milligrams IV as the fifth and final dose after a consultation with one of our sort of clinical helpline. And so we have on the protocol up to 10 milligrams IV. In practice, how often that's utilized, I don't have the numbers on that. And I think personally, it is more a question of getting the basics, rather than massive doses of Narcan, but it was an interesting conversation.
All right, good. Yeah, and I got a call from, what do you call it, Mike Austin, no, not a call, but an email from Mike Austin earlier today. He couldn't join us today, but hoping that you'd be on, and then we're going to get Sheldon on next week, as you heard. So thank you for the contributions from the, from us in the lower 48 to our brethren to the north. So thank you so much. All right, let me see who else they meet. AJ, you want any comments to make from your end? AJ Heitman, if you're there. Any comments from you before I wrap this?
Yeah, Paul, nice
Crawford,
conversation.
I want to get Crawford too. I just totally saw that I missed him, but go ahead, AJ.
No, I'm working on the consulting side. I put a note up there. If anybody has experience working with the Navajo Nation, we're going to do a revamp of their whole system. It's a massive EMS system that nobody really knows about. And those that do tell you it's very antiquated. So any help from the Eagles would be appreciated.
And where is it located primarily?
Its a major portion is in Arizona and New Mexico.
Okay, got it. Okay, excellent. And is it on the northern side mostly of both states?
Yeah, mostly on the northern side.
Okay, got it. Okay, good.
I'll keep you posted.
And you put it in the chart, and then if you want, maybe even Jim can put something out to everybody. So we'll see. All righty, got it. So listen, let's see now. What else did I have here? So I wanted to, Crawford. Totally. Yeah, I figure here you are in morning, right? So sorry to. So anything to report from your? You always say, "Nah, not really anything," and then you report something really amazing. So that's good.
Well, I don't know about that. I mean, sort of our recurrent issues are violence and drugs. Violence-wise, I mentioned last week about our area in Philadelphia, Kensington, which is the epicenter for the drugs. But just sort of add insult to injury, we just had a mass shooting there over the weekend, Saturday night. 9 people were shot in one incident. All were transported by police to one hospital. So,
yeah.
And also, as I alluded to last week, we had a outbreak of very serious overdoses in West Philadelphia, which ultimately I think was attributed to fentanyl and crack. And so people were smoking crack thinking they were getting that, and they got fentanyl instead. And a couple of people died as a result. So just sort of the recurrent theme of life in Philadelphia.
Now, the pharmacist didn't check their formulation.
Yes, clearly not.
Oh, wow. Okay. Well, good. Well, it's great to see you. And like I said, enjoy the Eagles while you can. Okay, which is good. But it still was extraordinary that they did so well getting there. It was an amazing series. I enjoyed it so much, that kind of thing. So, all right. Well, good. I'm thinking, I guess we're good. Time to wrap up, I guess. Hey, Joseph, anything else you had to report? Were you able to zoom in a bunch of people? Okay.
Yeah, I think we went online. Great. I will just real quick. I run a workplace violence recording system in North Carolina.
That up. Yes, go ahead, bud. Go ahead. Yes.
Over the last couple of weeks, we've seen an uptick in reporting. I don't know if they finally just got to the point of reporting it, if it's changed the volume, but workplace violence for medics in the field is on the upsurge.
Yeah. And I remember Jose presenting in the past, but you guys have done a great job. And so has Rob Dunn and his group And I think I referred some people to both of you about handling the workplace violence issues, and because you've done some good stuff, but I think some of it's just unpredictable nowadays. I think that it might be a good thing to chart actually and start logging and then raise our ability, like the stuff that Dave Pearce went through with his group being shot at, responding to a fire. You know, just just some really bad stuff happening that just make the life you know, a little bit more worrisome. So for everything, I guess, but it is what it is. All right, so with that, unless anybody else have anything else to pipe in about or talk about or whatever, so. Well, if not, then welcome back, my friends, to the show that never ends. Next week, hopefully we'll get reports from both, not only from Sheldon about the double sequential, but also hopefully, I hope next week, but I think he may not make it on next week either, about the Uvalde thing from Mark Escott, but he says that he could probably do it the week after. So that'd be good. So we'll have that one coming on as well. All right. Well, with that, everybody, thanks a lot. Time for me to head off to my adventures here in the Windy City. So thanks again, everybody. Have a good evening. Be safe. And okay, take care. I'm Paul Pepe. I approve this message, right?
Take care.